Chairman, ladies and gentlemen, I will discuss some perspectives on heart-brain interactions dealing with atrial fibrillation. As you know, the atrial fibrillation is the most sustained cardiac arrhythmia in general population. It confers a five-fold risk of stroke, and these strokes are more severe, have a higher mortality, greater disability, and a higher health care cost. And there is also associated with AFib an increased risk of cognitive and functional decline. Facing a patient with atrial fibrillation, we very soon have to decide if the patients need to be anticoagulated or not. And you know since many years that vitamin K antagonists are associated with a 64% reduction in stroke and a 26% reduction in all-cause mortality related to placebo or control group. There is a lot of limitation with this vitamin K antagonist. As you know, there is a slow onset and offset of action, narrow therapeutic index, and variable and unpredictable anticoagulation effect, and, for example, multiple food and drug interactions. And of course, there is a need for monitoring of anticoagulant effect and dose adjustment. All these limitations may explain the suboptimal use of oral anticoagulation, and there is also for the physician a problem of perception with these drugs, because the fear of bleeding is interpreted as it's a doctor's fault, and when stroke happens, it's the nature's fault. The real-world data shows that only 50% of eligible patients actually receive AVK. And in these 50% of patients receiving AVK, only 60% are correctly treated with therapeutic range of anticoagulation. This means that not enough patients are treated, and when patients are treated, they are incorrectly treated. So now, due to these limitations, there are on the market new anticoagulants. But before discussing these drugs, what is the ideal anticoagulant? He has to be rapid and have a rapid onset of action. He has to have minimal side effect. If possible, no food or drug interaction. He has to be cost effective. These new drugs, you know, are Xaban family and dabigatran. And these drugs, as you know, in summary, are non-inferior in preventing stroke comparing to vitamin K inhibitors, are associated with a reduction of hemorrhagic stroke, and one of them is associated with a reduction of ischemic stroke. But also there are problems with this drug. They may lead to increased gastrointestinal bleeding. They have to be careful used when there is renal dysfunction. Whatever they are at least effective as warfarin with increased safety profile, so in such a way that they may increase the proportion of eligible patients who will receive the treatment, and they may increase the time in therapeutic range for those who will receive the treatment. But there are also some challenges in the widespread clinical adoption of these drugs. There is, as you know, no validated test to measure the anticoagulation effect, no established therapeutic range, no antidote yet for most of them. The assessment of compliance of the patient will be difficult as compared to vitamin K antagonists. We don't know if they have a long-term side effect. The cost efficacy is discussed, and there is a lack of head-to-head studies comparing these new anticoagulants. We observed during the last years, from 1992 to 2007, a decline in ischemic stroke, and it was associated with an increase in warfarin use in the patients. And we can hope that with this new drug, we may obtain a further decline in ischemic stroke, as we will have maybe an increase in anticoagulant use in patients suffering for AFib. So whatever the drug use, stroke thromboprophylaxis should be based on consideration of individual potential benefits and risk of treatment and patient preferences. I will now speak about ablation. As you know, one of the late conclusions of the ARFIM study was that it's well to be in sinus rhythm, but the drug was maybe not the best tool to maintain sinus rhythm. And if an effective method for maintaining sinus rhythm with fewer adverse effects was available, it might be beneficial. And one of these methods, or the best method until now to maintain sinus rhythm, is ablation. And many studies have demonstrated that AFib is better treated with ablation than with drugs. A recent study, non-randomized and observational study, showed a few years ago that in AFib patients treated with catheter ablation, the long-term outcome in terms of death, stroke, and dementia is favorable and similar to those without AF. And AF patients without ablation did significantly worse compared to those without AF and those treated with ablation. So, is it so clear and simple? We know from different studies that stroke, even during ablation, is around 1 to 2%, and these strokes are clinical stroke diagnosis by the neurologic examination. And these strokes are linked to the procedure. They may be linked to pre-existing thrombus or tear formation on the ablation catheter, or air or tissue embolism, or low level of anticoagulation, among others. If symptomatic stroke is around 1 to 2% in this ablation procedure, silent stroke is more prevalent, from 6 to almost 40%, depending on the technology used. And we know that ablation without irrigations are more dangerous in terms of brain protection. Some risk factors were evoked for this silent stroke, for example, cardioversion during the procedure or procedural low ACT. We know from MRI study that the prevalence of silent cerebral infarction is around 10% in the general population, but AF is associated with a higher prevalence, with an odds ratio around 2. We know also that the majority of these lesions are very small, less than 1 centimeter diameter. They disappear late after the procedure, and several months after the procedure, there may be only small scars from the bigger lesions. These lesions seem not to be prevented by continuous oral anticoagulation during ablation. They might be related to cardioversion, to spontaneous echo contrast, to cafe ablation, or to the duration of the procedure prior to heparin injection. Some animal models may help to understand what happens really. In a swine model, LA ablation, whatever the technique, was associated with microbubbles and microembolus productions. Cerebral embolization of these air microbubbles or microparticle debris like coagulated blood that approximate the embolic sources from catheter ablation can create new hyperintense punctuate lesions on MRI in canine model. Location and size of the recovery lesions correlate with pathological findings consistent with ischemic injury. So microembolization can account for the typical findings seen on MRI after catheter ablations of AF. And of course, efforts to minimize production of microbubbles and microemboli particles during catheter ablations are warranted. So, what may be the consequences of these microemboli? We know that some adverse neuropsychological changes after LA have been demonstrated in some studies, like neuropsychological finding after major heart surgery. But a recent study might help to understand the problem. This study compared 4 groups of patients. One group with paroxysmal AF, with PV ablation, pulmonary vein ablation only. One group with persistent AF, with pulmonary vein ablation and some other ablation in the left atrium. Patient with supraventricular tachycardia undergoing ablation, some of them in the left atrium. And a control group with a patient with AF awaiting for ablation. All ablation was performed under general anesthesia, and all patients had a neuropsychological testing before 1 to 2 days after the procedure and later at 3 months procedure. There were no cerebral MRI. And this study showed that an overall incidence of cognitive dysfunctions it was 24% at day 2 and 13% at day 90. There was no time-dependent cognitive decline in the non-procedural AF population, and at day 2 and 90, increasing left atrial access time was associated with post-operative cognitive dysfunction, but prevalence of cardiovascular risk factor, intraprocedural DC cardioversion were not associated with dysfunction. We know that AF is associated with all forms of dementia, that cognitive and functional decline are important consequences of AFib, even in the absence of overstroke. And in the absence of overstroke, people with incident AF are likely to reach thresholds of cognitive impairment of dementia at earlier ages than people with no history of AF. So, clinical stroke may have been considered as only the tip of the iceberg, and maybe the great problem with AFib are silent cerebral infarct and cognitive impairment. So if we put everything in perspective, what about anticoagulation, AF, and brain? Studies on anticoagulation have only addressed endpoint of clinical stroke and systemic embolization, but not silent stroke or cognitive dysfunction. Studies are needed to establish if anticoagulants are safe or dangerous in terms of cerebral microhemorrhages or neurocognitive dysfunction. As far as ablation is concerned, ablation in restoring and maintaining sinus rhythm may lower the incidence of clinical or silent cerebral stroke and prevent or delay neurocognitive dysfunction. However, ablation procedures are associated with a high rate of silent cerebral embolism with possible disabling long-term sequelae. Further prospective multi-center studies on AF ablation should include silent stroke and neurocognitive dysfunction as endpoints, and of course, safer AF ablation procedure should be developed to minimize the risk of cerebral embolization. Everybody in the field of AF ablation is waiting about the result of the Cabana trial, which is a prospective trial which will enroll 3,000 patients, but look at the primary endpoints will be mortality and the secondary endpoint, disabling stroke, hospitalizations utilization and cost. So this study will not answer the question about the relationship between AF treatment and silent embolism or neurocognitive dysfunction. I thank you for your attention.